Good afternoon to those of you on the eastern side of the U.S., and good morning to those of you around the country. It is a pleasure to be here today with you for the latest edition of the Systems for Action Research in Progress webinar series. My name is Anna Hoover. I am the co-director of Systems for Action National Coordinating Center at the University of Kentucky, and it is my privilege and pleasure to be your moderator for the next hour as we hear about the exciting new research looking at the different ways of bringing together networking, partnering across systems, across sectors to improve population health. Today we will be beginning with an excellent presentation from two investigators who I will introduce in just a moment, Danielle, Varda, and Adam Atherly. And that will be followed by commentary from Simone, Singh, and Kevin Barnett. I will give you introductions to all of these folks as we proceed through the hour, but I want to point out at this early moment in our call that we will be having questions and discussion at the end of the hour. So as questions occur to you, please make use of the chat box on your screen. You should have a chat box in your ReadyTalk conference screen. Post those questions as they occur, and we'll make sure to hit them at the end of the session, as many as possible. And it is now falling to me to introduce our esteemed presenters today. Danielle Varda is an associate professor at the School of Public Affairs at the University of Colorado, Denver, and she is the director of the CU Center on Network Science. Dr. Varda joined Colorado from the RAND Corporation, where she worked as an associate policy scientist from 2005 to 2008. Dr. Varda specializes in collaborative governance and network leadership, and her research focuses on evaluating the network structure of interorganizational collaborations between the public, private, and nonprofit sectors and the subsequent network effects of these recorded interactions. She has developed models and methods of network measurement, and with funding from the Robert Wood Johnson Foundation, is the developer of a software tool that uses social network analysis to administer a survey and link to an analysis tool to measure and monitor collaborative activity over time. Dr. Varda's partner tool is used by more than 600 communities in 30 countries and all over the United States. Her research portfolio includes projects in the areas of maternal child health, public health preparedness, nonprofit community networks, and systems evaluation. Joining Dr. Varda today will be Adam Atherly. Dr. Atherly is a professor in the Department of Health Systems, Management, and Policy in the Colorado School of Public Health. Dr. Atherly's main area of research is health economics, with an emphasis on the economics of aging and consumer decisions regarding health plan choice and health. Dr. Atherly has been working in public health services and systems research for several years, with an emphasis on measurement and economic issues, and he has completed many cost-effectiveness studies and has experience in health outcomes research, including scale development and evaluations of efforts to improve quality of care and patient safety. Dr. Atherly received his PhD in Health Services Research Policy and Administration from the University of Minnesota. Again, before I hand the controls over to Drs. Varda and Atherly, I want to encourage you to make use of those chat boxes. Danielle, the microphone is yours.
All right, good morning and good afternoon, everyone. Thanks so much for joining in today. My voice is a little hoarse, so just bear with me. Before I start, I just wanted to take a moment to talk a little bit about our team. You'll see on this slide all the folks, Adam Atherly, myself, Rachel Graham, Lisa Van Reemdonk, and Greg Tung, who make up this team. And I think something that's really notable about us is that this particular project is on a topic that's very interdisciplinary. And we're kind of always amazed at our own team because we all have a very different expertise and skills and experiences in these different areas. And together we make this really whole interesting team that does a lot of these, that works on a lot of these issues. And so for that reason, we're actually all on the phone. So Adam and I are presenting, but for the Q&A, we're going to encourage our whole team to answer. And I think you'll see how we kind of fit together in that way. And so just wanted to acknowledge everyone. As well, we wanted to acknowledge and thank the Robert Wood Johnson Foundation. We were one of the last Public Health Systems and Services awards for that cycle and of grant making, and that's what led to this work and some future work that we're all working on together as well. And it's been a real pleasure to always, of course, be a part of that program. So I'm going to start with a little background and get through kind of the first half of the presentation. we know that there are any growing number of national initiatives that are calling for greater integration between the public health and hospital systems. Some of the most prominent to all of us right now include healthcare reform, including the Affordable Care Act and IRS requirements that nonprofit hospitals conduct not only community health needs assessments, but develop plans to guide those community activities. And previous to that, we saw a push towards public health accreditation, the accountable care organizations, patient-centered medical homes, lots of different initiatives that are bringing integration between healthcare, public health systems, and also community organizations together more than ever. And this research, when we first proposed it some years ago, was largely in response to the IRS requirement that nonprofit hospitals report their community benefit dollar spending on their 990 returns. And we had interest in how that new requirement might affect different parts of the way that the system interacts together. So because of that, we began to expect that we would see some changes in the system. One, that we would see, of course, increased investment by hospitals in public health systems, for example, through their community benefit spending. Also, increased involvement and interaction by hospitals in public health systems. And so just before I go on, we all kind of have this moment of pause where when we started this work, almost any time we present it, where we get asked, what do you mean by the public health system? And so I wanted to clarify that really early on in the presentation. We really have defined the public health system broadly. So we're not, in fact, looking at just public health and public health organizations or organizations related to public health systems and services, but also those organizations throughout the community that have some impact on our public health system. So what you're seeing here is a slide, a little bit of data early on in the presentation. One of the data sets that we use has a large number of organizations in it that are all working together around some kind of public health topic. And we'll explain that later, but these organizations we coded by 10 sectors, the sectors you're seeing over on the right. There was a total of 7,816 organizations in them, and what we've called out there are the nonprofit organizations, of which 33% of the organizations in the sample are made up of nonprofit organizations. And so what we realized is that while we do have, you'll see in the system, we include local government agencies, schools, health departments, colleges, hospitals, and others. It was really a system made up of largely of these nonprofit organizations. So just to take that one step further, in later work, we went ahead and we actually took out those nonprofit organizations and coded them by their IRS designation to find out what kinds of nonprofits are actually making up most of these partners in the public health system. And what you'll see on this slide is that, not surprisingly, most of them were human services or health organizations. So we just wanted to kind of pause and let you know that when we are referring to public health systems, we're really talking about this system as a cross-sector, interdisciplinary kind of network of organizations that work together around public health issues. So the two questions that we're driving our study are, one, what indicators inform successful hospital public health partnerships, which we call interactions? And two, what indicators inform increased hospital contributions to community benefit? And we refer to that as investments. So we're really curious what indicators are informing successful interactions and increased contributions into these into the public health system. So our methods, our analytic strategy to approach this was to first develop a conceptual framework that would identify hypothesized indicators of increased hospital interaction and investment in public health systems that would that would guide us through the rest of the study. We then created a database of available indicator data for hospitals represented in the data. And thirdly, analyze these relationships between the indicators and data on two outcomes, hospital interaction and hospital investment in public health systems. So we're going to break that down just a little bit. So first of all, to develop the conceptual framework, what we did is we did a pretty in-depth review of peer-reviewed and gray literature. We know that there's a lot of folks, and many that we really admire, who have been doing a lot of this work, and including our commentators today, really looking at these different interactions and the ways that hospitals and public health systems are interacting. So we wanted to make sure that we covered and took a good look at what was out there. But we wanted to put it all together into some kind of conceptual model that we felt was comprehensive in terms of the indicators that could be included that we would be able to analyze to look at these outcomes. So we drafted that conceptual model and then brought together an expert panel to review and narrow it and further refine the conceptual model. So we brought them for an all-day meeting here in Denver. It consisted of 9 people, 4 from hospitals, 2 from public health, and 3 from other national organizations, experts in this topic area. Those people came together, and we just did a huge session for the full day and went back and forth on what we were missing and what went together and what went into what groups. And then we revised the framework based on some of that panel feedback. So this is the conceptual framework that we were ended up with. It's in a paper in Frontiers in Public Health Systems and Services Research, which goes into a little bit more depth. But what we did is we really kind of bucketed it into a few categories. So what you'll see, I'm going to start actually on the far right, which is our ultimate outcome. We were looking at hospital investment in public health systems. What you'll see in the purple box in between are these partnership characteristics. So, what really is happening when hospitals and members of the public health system are interacting. And what we found is that that could be both an outcome and also an input into the model. We could ask, do partnerships determine, is that a factor of hospital investment? But we also want to know if some of these factors are resulting in more partnerships, or what kinds of partnerships in these different interactions. And so the factors that we included based on all of that work were community demographics, which is kind of broken down in this paper that I referenced. I'm not going to go through all of them here. The legal and policy environment that a community or a hospital community might be involved in. The market conditions. Also the hospital organization and system, and the public health organization and system. And so we kind of put those in the center, and we separated them, but what we mean by that is that the organization type, so the hospital type, for example, whether they're private, public, or a nonprofit hospital, leadership and commitment of the folks inside the hospital, the organizational culture, and even the data capability and use can be factors that influence all of these, and combined with these other kinds of variables are things that can influence these outcomes in both creating partnerships and also making choices to invest in public health systems. So we used that framework, and what we did is, what I'm not showing you here, we actually went through the framework and tried to define where we had data that we could test the framework. And we understand that that framework is full of factors that we have a much larger, longer table of, and that those factors are very multifaceted. We believe we've always talked about this conceptual framework as being hypothesis generating and something that we feel like could use a lot more research. And so our next step in the work was to take as much of the framework as we could and find data on those pieces and then test them, knowing that we would not be able to test the entire framework. So what we did do, though, we had 3 pretty strong data sets to combine for this project, and we did that to identify as many of the factors in the framework as we could. So the 3, they're all secondary data sets, meaning that we did not collect the data. They were existing data that we used for this part. So what we did is we took the IRS 990 Schedule 8 community benefit data, and there's folks on our research team that are pretty well versed in this and have been working for years now in cleaning that data and dealing with some of the nuances and challenges of working with that data. So we feel pretty good about that. We did use data from the partner tool, which was mentioned in the beginning. This is a tool that we run out of the Center on Network Science. It's a tool that communities use to collect data on their cross-sector interorganizational networks. So we use that to identify hospitals that exist in the data set so we could better understand the relationships between hospitals and the public health system. And then we also had available data from the American Hospital Association annual survey data, which allowed us to identify some of the factors related, especially to the organizational systems of those hospitals. So we merged the data using Medicare ID. A little bit about that, it was not easy. Merging these data sets together was one of the things that was more work intensive on this project. So we basically were able, though, to get multiple matching points to pull the Medicare IDs for hospitals by name and location. It was an iterative process with lots of data quality checking. And this is where we really started having in-depth discussions about what we meant by the public health system. So we made the choice not just to look at hospital public health partnerships, but hospital public health system partnerships. And our team can talk more about this process, but our end result was this merged data set. And just a little bit about it, we found 134 unique hospitals. This is kind of a layout of where they are, so clearly we're not completely geographically represented in the data, but this is what was available. So you'll see kind of how they're grouped in different places. We had 200 observations, some repeated within and across years, and the sizes ranged from 16 to 2,083, and on average 284 beds. And just one last slide that I'll present before I'm going to pass it over to Adam, just to give you an idea. He's going to talk about a specific way that we use the data to look at this question through an inferential model. But just one point of descriptive analysis here. We thought this was interesting. In the data, we have measures which are perceptions by partners of the hospitals in the data set. And this we show because we've done this kind of analysis several times with hospitals and perceptions of hospitals. And in cross-sector community collaboratives like this, networks, we often find that hospitals are reported as being highly trusted. And so lots of folks do feel like they have high perceptions of hospitals and the ways that they might interact with them on these issues around particularly public health systems problems. They also tend to have very high perceived values in power and influence, but that you'll see here those levels drop. The red line indicates we consider a score of 3 or better good. So where you'll see it really drop is on resource contribution. So there's still, even though many of the partners in the community believe that hospitals are very trustworthy in terms of reliability and mission concurrence and open to discussion and have a lot of power and influence, we do see there's a perception that they have a lower amount of resource contribution than perhaps they could in communities. So just kind of an interesting little point in the data that we saw. But what I'm going to go ahead and do now is pass it over to Adam, who's going to talk a little bit more about our inferential analysis. So here you go.
Great. Thank you, Danielle. And I want to reemphasize what Danielle said, that this has been very much a team effort. And as Danielle and I have been talking about this, it's been sort of interesting for just to have only 2 of us talking about this, because different people on the team have very different expertise, and sort of there's a piece of this that everybody knows really well. What we wanted to do in terms of the analysis was we wanted to take the conceptual model that Danielle showed you earlier and then take all of our various data sets and then operationalize that conceptual model. The ultimate thing we want to understand is what is the relationship between what we say here, the level of community engagement in the public health system, and the investment by the hospital in that system. So the way we did this is we did a multivariate analysis. We did a generalized linear model, and we did, for those who like this kind of thing, like me, it was a log link and a Poisson family. We also, as Danielle said, we do see some hospitals multiple times in the data, so we clustered our standard errors on hospitals. The dependent variable, and I'm going to go through, I'm going to tell you the dependent variables are key control variables and our other factors, and then I'm going to go through in detail each of those. So the dependent variable here is the percentage of revenue spent on community benefits by the hospital. And again, I want to emphasize this analysis is looking at hospital behavior. So we're trying to understand what factors influence how much hospitals spend on community benefits. We controlled for the key variables we're interested in is the network engagement. So how does the hospital interact with the public health network, and how does that interaction with the public health network influence the hospital's behavior? And then we want to control for all the other factors suggested by the conceptual model, which I'll go through.
Sorry.
The mouse is a little too far away.
Okay.
So the dependent variable is, as I said, a measure of community-engaged community benefit activities. This came from the IRS 990 data. So all the hospitals who are, and I should say that all of the hospitals in our data set are nonprofit because the data set is based on the IRS filings by nonprofit hospitals. So for these nonprofit hospitals, they're required to, under the Affordable Care Act, they're required to file their 990 forms and explain where their spending is in terms of community benefits. There's a lot of different categories where hospitals can spend their community benefit dollars and have it counted. And what we did is we looked at three particular kinds of spending. Spending by the hospital on community health improvement and benefit operations, cash and in-kind contributions to the community, to the public health network, and also money that they spent in community building. And we combined these three together to measure the amount of community benefit spending on public health activities by the hospital. And we didn't look at these three categories separately because previous research suggests that there's some inconsistency in how hospitals put their dollars into these three buckets. Community benefit dollars that related to public health tend to be in one of these three categories, but again, it's inconsistent which of the three categories they spend in. Then we took those community benefit dollars and then we divided that by the total revenues to get essentially the percentage of total operating expenses that they spent on community benefit, and that's our dependent variable. The key independent variables in terms of the network is we had 5 measures of hospital participation in the public health system. And these are variables that Danielle has, from Danielle's partner tool that she's developed and validated over many years of research. The first is the degree centrality. So that's the number of the connections a network member has with other members of the network. The second is value, and there's 3 different dimensions of value that are ranked by other members of the network, which is the value of the network to the hospital. The third is the trust, so that's the amount of trust that members have put in the hospital in the network. The fourth is the breadth of the network, and so this is the proportion of different organizations existing in the network by high, moderate, and low, moderate, and high diversity categories. So essentially what the breadth is measuring is the amount of different kinds of organizations that are participating in the network. And finally, the relative connectivity, and so that's the benefit to the hospital from the network relative to the most trusted or connected member. So we've got a couple of different measures of, so what we essentially have is a measure of value, trust, the connectivity, the breadth of the organization, and the size of the organization, of the network, sorry. In terms of other independent variables, again, these are drawn straight from the conceptual model. So these are the key factors that we found in the focus group and also in our review of the peer review and gray literature. The first is hospital size, and our hypothesized relationship is positive. We thought in general larger hospitals likely spend more on community benefits. Hospital size, there's a number of different ways to actually operationalize hospital size. The way we did it in this is the number of beds. You could also do it by the number of FTEs. We tried it different ways and it didn't make a lot of difference. The next 2 variables, payer mix and net revenues, are a measure of essentially how much free revenue the hospital has. In other words, how flexible is the hospital in terms of how much money they have. And the first one, payer mix, the idea is that in general, for public payers, Medicare and Medicaid, reimbursement rates for hospitals are generally fixed, and there's not a lot of play in it. On the other hand, for a hospital that has a lot of private insurance, they'll have a lot more play in how they spend their revenue. So the notion is that as a hospital has more private or more public dollars, they're going to have less flexibility, and so you should see less spending on community benefits. And we also thought that relationship might well be nonlinear, so we put in not only payer mix, but payer mix squared. The second way we measured this revenue variable was through net revenue, which is just essentially spending over revenue to try to, and again, the idea is that as hospitals have a higher net revenue standing, they have more money to spend, and we would think they would spend more. We controlled for whether or not the hospital was a teaching hospital, the number of HMO contracts, whether or not they were rural hospital or an urban hospital, whether or not they were a Catholic hospital, and finally whether or not they were a sole community provider. We also did some interaction terms. So what we thought is that the relationships between the between the network variables and the community benefit spending may vary depending on the net revenue of the hospital. It's great to think that the network is valuable and that you're well trusted, but if you don't have any money to spend, it doesn't really matter. So the idea is that what we thought in terms of the interaction relationship is that if you have a combination of, say, a hospital with both lots of revenue that they can potentially spend on community benefits and also high value in the network, that interaction should be important. In terms of results, and what I'm showing you is here, I'm just telling you which variables were important in the model with the p-values in it. The coefficients are not standardized, and so they're sort of hard to interpret. But in terms of the main results, what we found is that the important factors for our hospital spending in terms of the network variables was trust was the big one. So the higher the level of trust, the higher the level of spending on community benefit dollars. And the second is the perceived benefit from participating by the hospital. So if the hospital perceived higher benefit from participating in the network, then they also spent more dollars. Spending was unaffected by the size of the network. That's the breadth variable that we mentioned before. The size of the network, the diversity of organizations in the network, and the value of the network as perceived by other members. The relationship between the community benefit spending and the network we found did vary depending on this interaction term as we hypothesized. So what we found is that both of the significant network effects were even larger for hospitals which had higher net revenues and also more private payers. Other control variables in our model were largely insignificant individually, but they were jointly significant. The payer mix was one that did matter. It had a statistically significant nonlinear relationship, so both the main effect of payer mix and also the squared term were both statistically significant. And as I said, in general, the other variables had the expected sign but were statistically insignificant. So what we conclude from this then is that community benefit spending by hospitals is affected by the hospital's trust and perception of benefit from the public health network for the hospital itself. This effect is magnified by hospitals with greater and more flexible revenue. Spending was not affected by other characteristics of the public health network, including the size of the network, the breadth of the network, and the overall network perceptions of value. And finally, other hospital factors are largely insignificant. And again, we spent a lot of time building the conceptual model here to understand what factors should explain it. But again, we found things like size, whether or not they're a Catholic hospital, teaching hospital, all those things were largely insignificant, in contrast to the network variables, which were very significant. So we found, so the implications, it's possible that hospitals that spend less on community benefits spend more on relationship building in the community. We can't rule out that possibility. So that then leads us to questions about what is the dollar value of building strategic, strong relationships between hospitals and public health systems, and how does that compare to actual per dollar investment? In other words, what's the value of the social capital in these settings? And finally, can hospitals that spend less in community compensate for that by investing greater time and effort in relationship building?
Thanks so much, Danielle and Adam. I would like to encourage folks again, as questions are occurring to you, to go ahead and be using your chat box to plug those in. I already see several teed up, and we'll be getting to those in just a moment. But first, we want to hear from our esteemed commentary panel. I will introduce both of our speakers and then hand the mic over. First, we have Dr. Simone Rauscher Singh. She is an assistant professor of health management and policy, trained in accounting and finance. Dr. Singh's research agenda focuses on improving our understanding of accounting practices and financial management strategies of both healthcare and public health organizations. For the past 4 years, Dr. Singh has been engaged in research related to legal and financial aspects of not-for-profit hospitals' provision of community benefit and how hospitals' community benefit activities can be used to improve population health outcomes. In addition, Dr. Singh conducts research on costing healthcare and public health services. Most recently, the focus of her work has been on examining differences in productivity and efficiency in service delivery across local health departments. Dr. Singh received her PhD in Health Services Organization and Policy in 2010 and her MA in Applied Economics in 2007, both from the University of Michigan. After we hear from Dr. Singh, we'll hear from Dr. Kevin Barnett, a senior investigator at the Public Health Institute. Dr. Barnett has led research and fieldwork in hospital community benefit and health workforce diversity at PHI for over 2 decades, working with hospitals, government agencies, and community stakeholders across the country. Current work includes a partnership with the Governance Institute and Stakeholder Health to build place-based population health knowledge among hospital board members and senior leadership, a national study of hospital interventions to address food insecurity and convene regional meetings of hospital and community teams with community development financial institutions to design intersectoral health improvement strategies. First, we'll be hearing from Dr. Singh.
Thank you, Anna, and thank you for the opportunity to comment on this really important and timely work. So we all know now that the Affordable Care Act has promoted a greater emphasis on population health. And as we've heard, for nonprofit hospitals specifically, this shift has brought about several new requirements. And the one that's maybe most commonly heard of is that requirement that hospitals now have to conduct these periodic community health needs assessments. And they are supposed to be conducted with input from a broader community and public health perspective. And then hospitals also are to develop these implementation strategies that address identified needs. There's recent work that has been conducted by researchers in Ohio, Missouri, Texas, and several other states and regions that has shown that this new requirement of having to conduct these CHINAs, or community health needs assessments, is indeed motivating hospitals to develop community-based partnerships, particularly, and that's, I think, a crucial finding in medically underserved areas. So given the number of stakeholders involved in the public health system, as Danielle has shown, and the complexity of the relationships among these stakeholders, it has been really challenging for myself and for many others in this area to really adequately characterize the partnership between hospitals and the large public health system, and also examine the impact of different forms of partnerships on hospital investment in population health activities. So for this reason, most of the past research was really focused on the relationship between hospitals and governmental public health, because we have fairly good data thanks to the profile surveys of local and state health departments conducted by Nature and ASTO. So the partner tool is really a very unique database that opens up new opportunities here, because it contains this very rich data on many more stakeholders in the public health system than just governmental public health. And so combining partner data, as Danielle and Adam and their team did, with data on hospital community benefit spending really allows for a much more nuanced examination of the interaction between hospitals and the public health system and how that translates into investment in community health. So I want to commend the team for their efforts. I know from my own experience it's not easy to merge these data together. There's no unique identifier. This is a time-consuming effort, and so it's great that you were able to do this. So let me just provide a bit more context. So what do we know about hospital investment in community health? Right? So we have some prior evidence, specifically from Form 990 that hospitals have been required to file, nonprofits have been required to file for the past several years, since 2009. And so we know that actually the majority of spending that's reported there goes toward clinical care. So about 85% of total community benefit spending goes toward charity care, Medicaid payment shortfalls, and other subsidized health services. And only a very small proportion, about 5 to 6% of total spending, goes to these broader community health, population health services. And so we are doing currently some additional research, and that has shown or is showing that the spending levels have increased a bit over the years since 2009, but the composition has really largely remained unchanged since the 2009 requirement began. So what drives hospital investment in community benefits? So we know some things, right? And a really important contribution here of the work that Danielle and Adam have presented is that conceptual framework. I think many of us have implicitly used a framework like this in our prior work, but it's nice to actually have this framework because it does point to many important potential factors. So we have some idea of what drives investment. So we know that hospital characteristics typically do matter, including the size, system affiliation, financial performance has been found to matter, especially for those more discretionary spending elements, such as the broader population health activities. We also know a little bit about medical conditions. We know that the share of for-profit and public hospitals in a community can matter. And then with respect to the legal or policy environment that was in one of the boxes, we do have some evidence that state-level regulations, so such as a state-level reporting requirement, matter, so that hospitals in these states provide more benefit. So what we really don't know much about is how partnerships with public health really impact spending, right? So this research really, that the percentage data really fills an important gap in our understanding of what drives hospitals' investment in community benefit activities. So I found it really encouraging to see that there are actually specific characteristics of the public health network that are associated with spending on community benefit, right? So I think that's a really important and policy-relevant finding because it appears to me that network characteristics aren't necessarily fixed, right? I mean, with the right initiatives and incentives, you may be able to change or improve partnerships, right? And so that may then, be an important factor or driver for hospitals' willingness to invest more in community benefit. So I wanted to end with just a few comments on, some potential limitations and also how, you may want to go forward from here. So my first comment is sort of on the sample size. And of course, you have a fairly small sample of hospitals here just because that's limited by the amount of partner data and partner communities you have. There are about 3,000, close to 3,000 nonprofits in this country, and so it'd be important or interesting also to know how the ones you have in your sample compare to everybody else, right? Is it a fairly representative sample, or does it sort of under or overrepresent certain types of hospitals? My second comment is that we know that the spending data that's reported on the 990 form is noisy, so there's a lot of error in the data, especially for the categories that you've looked at in the study. The main reason here is that before 2009, hospitals didn't really have to track many of these activities because there was no requirement for many hospitals, so there was just no need to do this. So there's been a learning curve that hospitals have gone through in terms of improving their systems. But we do know that especially the community building activity data is fairly unreliable, and so maybe you want to redo your analysis or rerun it and separate out the buildings. And finally, one final point is a little bit more broadly, spending has been used obviously in many studies just because we have the information, but we really don't know exactly what activities these dollars go toward, right? Are these key community needs or priorities? Are these, programs effective, efficient, right? We still don't know a lot about how managers make decisions around community benefit programming. And so anything I think you can do to sort of further get at that would be really valuable in the context of, bringing together this public health framework with hospital investment and community benefits. So thank you very much.
Thanks, Simone. Kevin?
Thank you. And as Simone did, I want to commend Danielle, Adam, and their colleagues for this important study. I think it highlights both the importance of conducting research at this level, as well as some of the challenges in digging into some of the details, in essence, getting under the hood. And Simone began to do much of that. So I will do my best not to repeat the points that she made and select some other areas that I think are important to consider in this process. As Simone did indicate, the area of interest for those of us on the, whether you call it public health, population health, place-based population health, whatever you call it, that it focuses on addressing not simply the symptoms, but the real drivers of poor health in our communities. A key issue, and this goes back to research by Rundle and Silfair in the 80s, said that in fact hospital location means more than the Articles of Incorporation. Now, of course, those of us that have support the nonprofit sector would contest that, but we definitely have dynamics that are in play that determine the relative degree to which a hospital is engaged in supportive and addressing these determinants and focusing their resources where inequities are concentrated. So, so it's hard to get at that. You use some important variables to control, but even within that dynamic, looking at where the hospitals are allocating, in essence, where they're allocating. When we did a study in 2013 for the CDC, one of the things we began to get at is that how hospitals define their communities in their community health needs assessment often provided and illuminated the degree to which areas, census tracts, where poverty and related issues are defined, high school non-completion, in essence, good proxies of health disparities, were often carved out of communities and or not the focus. Hospitals that tend to be located more proximally to these populations, of course, have them coming into their emergency rooms, and their payer mix may make it more difficult for them to invest their dollars in a more upstream way. In contrast, you see some of the hospitals that have a positive payer mix may be located in more affluent areas, may very well spend more of their dollars in an upstream way. The question is the degree to which those resources are actually directed in those census tracts where health inequities are concentrated. So that is to speak to, as we look at the aggregate, as we look from the 40,000-foot level at this work, it's just as important to begin to look much more closely at the local and regional level, to engage and to examine the dynamics underneath in terms of how resources are allocated, where they're allocated. And when we talk about the concept of a network, it's important to recognize that not all members of the network are equal contributors to addressing issues. We have an immense amount of parallel play going on in our communities, duplication of effort, waste of resources, and how do we begin to get at that? How do we begin to engage our hospitals, our public health and social service agencies, our community-based agencies, in a more substantive way to dig at these? So those are just questions that are out there that don't get addressed. The important thing that this research does is begin to frame a way that folks can begin to dig deeper into this. And I would just note, and I'm going to stop now to make sure we have a full 15 minutes for conversation, that we are about to launch a new national center, the Center to Advance Community Health and Equity, that will have, among other tools, a tool called Community Benefit Insight that will have all the hospital 990 Schedule H's, and it's a searchable site that will enable both researchers as well as community-based organizations to quickly get at and compare the relative contributions in each of these content categories that are talked about in this study. So part of the purpose of that is to help drive a more deliberate and focused dialogue at the local and regional level among hospitals and community stakeholders about how to begin to move these resources from the downstream treatment of what are often preventable illnesses in the ED and inpatient settings to how do we better target them to address the real drivers of poor health in our communities. So we'll be launching this center and this tool in September of this year.
Thank you, Dr. Barnett. We do have several questions teed up, but before we get to that, I want to give Drs. Varda and Atherly an opportunity to respond if they would like to address anything raised by Dr. Singh or Dr. Barnett.
You know, we don't really have any comments in return, except we just really want to thank Simone and Kevin for being so articulate and helping to summarize this work. You know, we can tell that we're partners with you in thinking about the future of this work, and just amazed at the kinds of ways that, Simone, that you just framed many of the pressing and future questions. And Kevin, I think everyone on the whole webinar is writing down the new tool and center, and so it's very, very exciting to know that you all are pushing this work forward. And so we're just really grateful that you were on this call today and hopefully partnering with us in the future on all of this work together. So thank you.
Thanks, Danielle. And Kevin, Danielle did mention it, and I know everyone is scrambling to write down the name of the center. Would you mind restating the name of the center and if there's any additional information, website or related that folks could go to for more information?
You bet. There will be two URLs that are linked. One is the Center to Advance Community Health and Equity, or CASH, and they framed this as a treasure trove of tools and resources to advance practices. And then the Community Benefit Insight, or CBI. So again, they'll both be launched in September, and you'll be able to Google either one of them that will bring you to those sites. And the CBI is one of a number of tools. Another one is a tool that we developed in working with the Community Commons that actually uses GIS technology to really begin to identify where hospitals are, where jurisdictional boundaries are, where concentrations of poverty, high school non-completion, and others are at the census tract level. And through that, begin to look at the degree to which, as hospitals define communities, as part of their community health needs assessment, how are they engaging stakeholders, how are they setting priorities, and then the content and geographic focus of their investments.
Thanks so much, Kevin. I know we had several questions from folks who didn't quite get it written down, so thanks so much. Switching gear for some of the questions for the Colorado team, Craig Schmidt, going back to our results slide, Craig Schmidt had a directionality question, wondering if the trust finding is more a result of the spending or if the spending results in more trust.
So this is Adam. That is one heck of a good question. And that is a question that the research team we chased our tails on it for quite a long time, because it is entirely possible that if the hospital spends more, they become more trusted, rather than if they have more trust, they therefore spend more. This should very much be thought of as associations. And there is just no way that, when you think about the usual approaches to try to get at that directionality in terms of things like instrumental variable modeling and, there's a number of fairly standard techniques. We don't have any of those. We were not able to figure out how to operationalize any of those ideas. And so I think that's a point that should have been emphasized and was not going through, is that this is an association.
Thanks, Adam. Moving on to a couple of questions from Julia D'Angelo, who wonders, first, if you looked at the quality of hospital partnerships, for example, produced measurable outcomes, and secondly, whether you also looked at hospitals with advocacy or government affairs departments' relationships with interaction and investment.
Yeah, I'll take that one. We didn't look at any level of the hospital like that, whether they have advocacy or government affairs departments. It's just a level of coding that we didn't do, and so it's a terrific question. I can see why you're asking it. We thought a lot about the fact that the hospitals. There's so many factors of things that are happening inside the hospitals that we may not know about that could be influencing all sorts of things. Not only how they interact, but how they make decisions about investments. So unfortunately, no, but it's a good idea. And then the other one, did you look at the quality of hospital partnerships? So we just looked at. We kind of rate the quality of the relationship based on these. We use the perceptions of value and trust. I'm not sure what you mean by produced measurable outcomes. So we can kind of tell if the relationships are, for example, have more of an exchange of resources versus that they just have awareness of each other. So we can look at like what they actually do together. We didn't use that as a variable in this primarily because when we're aggregating the data at such a high level, it's really hard to normalize measures like that across different networks because there's different ways that people operationalize what they do together. So it's sometimes not even actually possible to take multiple hundreds of networks and make them look across the same. So we're trying to use the measures that make the most sense in aggregating at that level. So we did use the value and trust questions, though, are the ones that everyone has in all of the data sets. And so on those questions, we're able to look at perceptions of one another in terms of those value and trust measures. And so we do consider those measures of quality between any two partners, any dyad in the data set.
Hey, Anna, this is Lisa on the team. And I would just add, Julia, that back to the first question, the question about hospitals with advocacy or government affairs departments, there are a few other departments that our expert panel and our early work indicated might have some sort of differing influence about their investment and partnership. That includes marketing and communications departments and research departments. And they don't all necessarily equal in-depth partnerships or in-depth investment. In some cases, we heard from our expert panelists especially that if partnership just sits in marketing and communications, that then it has a little bit more of a surface feel as opposed to a really in-depth feel or in-depth work within the rest of the hospital system. So great question on that, but there's also other departments that have impact.
Thanks, Danielle and Lisa. And for those of you who didn't see the earlier slides, that was Lisa Van Rimdonk with the Colorado team. So good to hear your voice. Moving on to the next question we have from Nicholas Sinclair, who wonders how you determined the hospital's perceived benefit from participating in community benefit.
Yeah, that one. We didn't actually measure the hospital's perceived benefit. So there's no variable that says the hospital perceived a benefit from participating in that kind of spending. So that was probably a misunderstanding of all the jargon that we've used. So we only have perceptions of hospitals on things like at the network level, which we didn't actually use in this model, like their perceptions of the success of the network's outcomes, things like that. And so because it's secondary data, we just were able to take what's there. And so in all of the data that we found, there is no perception like that. But we add to our list all the time of things that, if we were to create a new survey or a new way to collect primary data, that we would include things like that. So we think that that is a key measure to how we understand hospitals' decisions to participate in community benefit activities. And so we would indeed love to know more about that or suggest that someone include that in their study as well. So thanks for the question. I wish I could say we had that variable.
Julia D'Angelo asks a two-part question. Are your research findings available in a publication yet, and can you share the list of hospitals included?
So we're working on our last publication, which we hope to submit at the end of the month, which writes all of this up. So stay tuned. We'll hope to get that out soon. But we actually don't identify the hospitals. So right now we don't have a plan to release them, and it's just because in the data we just basically get them down to a code and code them that way. And it is not our plan actually to release the hospitals that we included in the study.
One of the exciting things about the Research in Progress webinar series is it gets folks excited about these forthcoming publications. So be on the lookout for that, and if you're not on our mailing list, let us know, because we do try to let folks know when exciting publications come out from current and past grantees.
And actually, though, I did want to mention, I had mentioned it briefly, but we do have the publication out in Frontiers in Public Health Systems and Services Research, which publishes the Conceptual Framework and explains it in more detail. And that paper is just called The Conceptual Framework for the Study of Hospital Interaction and Investment in Public Health Systems. So our first half is there, and then we hope for the rest to come out soon.
Excellent. We have just a few minutes left, and we have several questions, so we'll get to as many as possible. And if we don't get to your question, I apologize in advance. We have a question from Desiree De La Torre, who would like to know if you'll take what you've learned about investment to measure its impact on health outcomes. And have you measured how community benefit investments change between CHNA cycles?
So I'm going to defer to our team.
This is Lisa, and I think I would say the quick answer is no. And what we were really hoping when we started this project was that in doing it and talking about it and having the expert panel and this kind of presentation, that we were going to be part of a larger sort of research interest. So we're hoping that this is inspirational work to others, especially the conceptual framework, and we would love to see you all doing some of this research as well, and we would be happy to be sort of your partners or thinking partners in doing that.
Yeah, and this is Adam, and I would add, I agree completely, and I would just add to that I think that's a great question of sort of what's the effect of this community benefit spending on health outcomes, and I think there's a lot of research going on in that area, and that's a little bit beyond the scope of what we're trying to do. We're just trying to understand what factors explain hospitals' decision to spend community benefit dollars, and then again, I think then there's a lot of people looking at this question of what's the effect of community benefit dollars on health outcomes in the community.
Excellent. Thank you for that. And we have a question from Kathleen Hennigan. Did hospital consolidation impact your analysis?
No, I don't think so. I mean, I don't. That issue never came up during our discussions, and I don't think any of the hospitals that we were looking at consolidated during the course of our study. And we definitely did not look at factors like, what was going on in terms of the marketplace for the hospitals. Now, if you look at the conceptual model, the market that the hospital operates in, both the competitive market and the legal and political framework they operate in, is definitely an important factor, and those are not included in our model. When we looked at those again, when we think about the market factors, the key one we looked at was just the net revenues, and then also the public-private payer mix.
Excellent. Thank you, Adam. And I see that we are just at time, so I apologize to those whose questions we did not yet get to. We will be sending out the slides from this presentation and encourage you to reach out directly to the investigators who are best positioned to answer your questions. We also have here a list of where you can find our webinar archives to look at this and past presentations, as well as any upcoming webinars we have on coming up on the 23rd, Comprehensive Population Health Systems and Hospital Uncompensated Care Costs. We have a presentation on September 6th on interorganizational relationships and public health system efforts to address prescription drug abuse. Are you detecting a theme? Then we have AFIX, a multi-state randomized control trial to increase adolescent HPV immunization through provider best practices. So again, we're looking through Systems for Action at how we can work across systems to improve population health. I want to thank again our presenters today, Dr. Danielle Varda, Dr. Adam Atherly. I want to thank Lisa Van Rimdonk there as well. We'd also like to thank our commentators, Dr. Simone Singh and Dr. Kevin Barnett. We encourage you to visit the Systems for Action website, follow us on Twitter, and we acknowledge that this is a program, a national program of the Robert Wood Johnson Foundation. Thanks to all of you for joining us, and we look forward to seeing you next time. Have a great day.